Good morning, everyone. We're going to bring the meeting to order. I want to ask everyone to turn their cell phones to silent. You may notice board members accessing their laptops, phones, or other devices during the meeting. They are using their devices to access board meeting materials that are in electronic format. This is an official business meeting of the Medical Board of California. As such, disruptions of the board's meeting will not be tolerated. We have a designated time on the agenda for public comment and ask for public comment on each agenda item. I ask that you be respectful of the need to conduct the board's business. Should anyone disrupt the meeting, I will ask that person to conduct him or herself in such a manner that permits the board to transact its business. The board welcomes public comments on any agenda item, and it is the board's intent for us to ask for public comments prior to the board taking action on any agenda item. If for some reason I forget to ask for public comment on an agenda item and you wish to speak on that item, please raise your hand or come forward and you'll be recognized. I would like to request that all speakers complete a presenter slip so I can call you by name at the appropriate time and that the record of the meeting can be full and complete. However, this is voluntary. Please give the speaker slip to Ms. Cruz-Jones. Thank you, Ms. Cruz-Jones. I would like to do my best to call upon everyone who has supplied a slip for the agenda item and recognize those who wish to make last-minute comments. This meeting will be available via teleconference. Individuals listening to the meeting will have an opportunity to provide public comment and will be assisted by a moderator who will be facilitating the teleconferencing process. For those members of the public participating via teleconference, please wait until the moderator has introduced you before you make your comments. To request to make a comment during the public comment period, press star and you will hear a tone indicating that you are in queue for comment. If you change your mind and do not want to make a comment, please press star. 2. Assistance is available throughout the teleconferencing meeting. To request a specialist, press star 0. Each person will be limited to 3 minutes per agenda item. However, that time frame may be subject to change depending upon the number of speakers on the topic. During item 17, public comments not on the agenda, the public has limited time to, the board has a limited total public comment period for individuals on the teleconference to 20 minutes. In addition to total public comment for individuals here at the meeting, it will also be limited to 20 minutes. So therefore, after 20 minutes, no further comments will be accepted. During public comment on any other agenda item, 10 minutes will be allowed for total public comment period from individuals on the teleconference line and 10 minutes for those in the audience. After 10 minutes, no further comments will be accepted. Each person will be limited to 3 minutes per agenda item. Business service office staff will be assisting me with receiving the public comments via teleconferencing during this meeting. I want to remind all speakers to please stay on topic and keep your comments to 3 minutes or less. We plan to end today by 1 p.m., really by noon. If you are a member of the media and require assistance or information, please see the board's public information manager, Carlos Villatoro. If individuals are in the audience, Ms. Lally, are there any special guests today?
Not today.
Okay.
No.
I would like to call the meeting to order and ask Ms. Cruz-Jones to call the roll.
Let's read then.
Ms. Friedman?
Present.
Dr. Gonadev? Here. Dr. Hawkins? Dr. Kraus?
Here.
Ms. Lawson? Here. Ms. Lubiano? Dr. Lewis?
Present.
Dr. Mahmood? Yes. Dr. Thorpe? Mr. Warmoth?
Here.
Mr. Watkins?
Yeah.
Dr. Yip?
Here.
Ms. Pines?
Here, we have a quorum. I would like to remind the members again that we will be taking roll call on all action items. Moving to agenda item 17, public comments on items not on the agenda. Before we invite the speakers to come forward, I would ask individuals making comments to not discuss pending complaints, pending licensing applications, or pending disciplinary actions, as this may come before the board for a decision. Such discussions are considered ex parte communications, as they could provide information to members that is outside the record in violation of the Administrative Procedure Act. Therefore, such discussions could create a conflict and lead to the board decision being challenged in Superior Court. The board can receive comments regarding the board's processes in general, but cannot receive comments on specific case circumstances where the decision is still pending. Board staff is available to speak to you about any pending matter. In addition, the board would like the public to address the board as a whole and not to individual members. Please be aware that the public comment during this agenda item should provide information to the board members and is not a discussion between the board members and the public. The only action board members can take is to listen to the comments and decide whether or not they want it as a future agenda item on the topic. No other action can be taken at this meeting. Though this may seem at times like the board members are not being responsive, following these guidelines is critical to ensure the rules of the Open Meeting Act are followed to avoid compromising the speaker's goals or the board's missions. I have the following speaker slips. Ms. Hannah Reed.
Good morning, members of the medical board, audience members. I first want to thank you for your patience and your understanding. You all, even though we don't have a verbal interaction, I've learned so much listening and attending these meetings. I understand that to affect change needs to start with me. So I thank you. I sincerely thank you for being patient with myself and others. So going back to the outburst I made yesterday, again, thank you for reminding us of the rules, not to single out board members. I'm very concerned about speakers, well-intended, I guess, but we at Black Patients Matter are very upset that some speakers single out underrepresented minority board members or any other board members, and that's not called for. It's not appropriate. It's against the rules. And it qualifies as, maybe hate speech. And so certainly we have 2 armed policemen, and so they can escort the individual out. And so thank you. So that was that yesterday. And then today, it's nice to see that we're going to, discuss further the ongoing healthcare disparity. And we at Black Patients Matter are very concerned about what's going on in Fresno. We believe that the ongoing healthcare disparity is due to many things, one of which is that we don't have enough underrepresented minority providers in certain areas of the state. Thank you.
Thank you. Faith Gibson.
My name is Faith Gibson. I am the executive director of the California College of Midwives, which is an organization that represents the legal and the legislative issues of California licensed midwives. In other words, it's not an educational institution. I'd like to say before going on to anything else that I've been coming to meetings here since 1993, which is when the California Licensed Midwifery Practice Act was first passed, and that the experience of what these meetings are like is very different now than it was then. I think you have an oceanic task that there's a lot of expectations that medical board members can just kind of say something and things will magically be different. And you know far better than I that that is not true. I think that the issue yesterday that we discussed, which is the VBAC, the agenda item 11B, number 1, is a problem that you guys did, that was before you, didn't have anything to do with you, and it's going to go on after you. And in the meantime, the best I think that we can do is to try to not make it any worse, in the sense of we're all dealing with the VBAC bans. So what I'd like to say is that there is a legal reason for not banning VBACs. One of them being, for example, an appellate court ruling in 1990 that defines as the only reason for obstetricians to do something against the mother's wishes, which is what happens when women are being forced into hospital births, only on extremely rare or extraordinary circumstances. I'd like to read just these little short bullet points. This is ACOG's opinion number 214. Medical knowledge has limitations and medical judgment is fallible. Existing methods for detection are not always reliable indications of poor outcomes, and there is often insufficient evidence for risk determination or risk benefit evaluation. Abiding by the patient's autonomous decision will provide the best care for the patient and fetus in most instances. In event of an emergency, the obstetrician must respect the patient's autonomy and continue to care for the pregnant woman and not intervene against the patient's wishes, regardless of consequences. These are their words, not mine. When a patient's autonomy is violated, a woman is wronged and may be harmed, whether physically, psychologically, or spiritually. The patient's subsequent loss of trust in the healthcare system may reduce the healthcare provider's ability to help her and may deter others from seeking care. There may be other social costs associated with this violation of individual liberty. I'd like to suggest, we were talking about a middle ground yesterday. How could ACOG and the midwives and the mothers kind of come together? Is that perhaps we could come together over this, that one of the things midwives often experience is women who say to us, I cannot go back to the scene of the crime. I am so traumatized by what has happened that I just can't go to the hospital, have my baby, unless there's something really bad going on for me or the baby.
Please conclude.
Yeah, so you get the point. Thank you. And I'd also be happy to do a presentation about midwifery in the sense of what it, the licensing that our law says that it is equivalent but not identical to nurse midwifery law. So we're not talking about two different categories. Thank you.
Thank you. Are there any comments on the phone?
We do have a first question coming from Colin Parker. Your line is open.
Hi, I was with you yesterday and I gave you the first part of what happened to my wife. Now I would like to let you know what happened with the board and their investigation of this. Originally, when I put this claim in, and I think it was 2013, I was told that they would get back to me as soon as possible. I was doing arbitration at the time, and a year later, they still hadn't got in touch with me, so I contacted them, and they said that the reason that nothing had been done so far was because the person allocated to the case had retired, and somebody else was getting on the case to replace her. Another year went by, and I got a contact from Duncan Fraser, who said to me, it was just before Christmas, and he turned around and said to me, can I talk to you after Christmas and meet up with you so that I can give you, or you can give me all the evidence you've got? And I said, yes, of course I can. He never did contact me, and because of the arbitration, I had to not deal with anything other than the arbitration. When I finally did get hold of him, I was told that, the case is finished, that no evidence was presented, so there's nothing to prosecute or discipline the doctor on. So between them telling me that the lady had retired and Duncan Fraser's antics, my wife's case never really got seen. So I want to know basically why people don't get the justice for their loved ones that they should do when a doctor has deliberately let someone die. And that is my personal opinion and the opinion of some of the other people. Because when somebody's got edema in their body, the first thing that they are taught as a doctor is to administer something similar to LASIK so that the water is drained out the body. My wife never was, and hence she died 23 hours after leaving the emergency room. And I think that the way I was treated by the medical board was absolutely disgusting.
Please
It
conclude.
looked to me as if it was done all deliberately because they didn't want to deal with Kaiser. So that is my complaint about
is
the
up.
way the medical board deals with it.
Caller, your time is up.
And we
Thank
have
you.
4 more comments.
Okay.
Susan Lauren, your line is open.
Hi, my name is Susan. 8 years ago today, Dr. Saul Berger surgically assaulted me in his privately owned ambulatory center. When I went to consult for a medically indicated breast reduction, Berger convinced me to add on a touch of lipo to smooth the contour on my upper lateral hip, or, he said, I'd look imbalanced and end up right back on the operating table. I objected and told him I was athletic, at my perfect muscular weight, didn't want added scar tissue, risk, pain, or much change to my body. He said lipo wasn't for weight loss. There'd be no scars or downtime, and he was the surgical expert. When I was unconscious, he stabbed me dozens of times into my buttocks, kneecaps, hip bones, iliotibial bands, and hamstrings without consent or rationale. He left me a bloody mess. The assault disabled me. He also took half of my healthy breasts. He used power-assisted liposuction by micro-air without my consent. PALS comes with a risk of penetrating the underlying structure. Berger told me he learned his skills at USC, but in Depot he said he learned PALS by reading instructions out of a box. I came to convulsing, stuffed into a garment I couldn't breathe in, sliced up in ways I didn't consent to, with body parts missing. His record-keeping was wildly inaccurate, inept, and fictionalized. He lied and wrote that contour correction was achieved, and there were no complications. His photos were manipulated and misleading. I was in horrific pain, numb lips, putrid metallic taste in my mouth, and more. When I told Berger, he slandered me to discredit me, which set me up for continued medical harm, and then he staged a cover-up. Your board let him continue to practice. I've talked to multiple other women who say Berger has harmed them since. Scientific studies show that liposuction creates an increase in toxic visceral fat, which is linked to metabolic syndrome, diabetes, cardiovascular disease, and more. Lipo causes remaining cells to increase in size, which is bad for health and aesthetics. Liposuction is a cash cow scam done by doctors who are not well observed or held accountable. I've studied the harm from liposuction since 2012. The cover-ups by surgeons and your board are staggering. In the Me Too era of women standing up against assault, the Medical Board of California will go down in history as one of the worst enablers ever. The American Society of Anesthesiologists said, quote, California's liposuction regulations do not prevent patient deaths, and the regulations specify requirement by volume of fat removed. These are too high. Patients die with even lower volumes, end quote. California Liposuction Code 1356.6 needs to be changed. Also, surgical assault ought
Please
to be a
conclude.
criminal act because it is. No one is above the law. And on behalf of everyone harmed by California surgeons, shame on you.
Thank you.
Eric Andrist, your line is open.
Hi, everyone. I'm calling from home today because I couldn't afford to stay overnight and pay another outrageously expensive parking charge. I think you all put these meetings in expensive locations so as to deter some people from being able to attend. We brought Colin in to tell his story, and he speaks for countless people that your staff is closing the complaints of illegitimately. I emailed several of you this morning with proof that Carrie Webb was once again wrong regarding Robert's Rules of Order. This very topic came up at the April 20th, 2018 board meeting when Brenda Sutton-Wills tried to make an additional motion, and Carrie said that the board has not officially adopted Robert's Rules of Order. I called in later in that meeting with proof from your own manual that states otherwise. Then she did it again yesterday, shooting down Mr. Watkins' motion to table the current motion, something that was absolutely legitimate. Then she had the gall to try and interject during my speaking time that she never said it. Well, when the video comes out, Carrie, I'll be putting both meetings on Twitter to show that's exactly what you said and that you were wrong. Most of the reasons I keep coming back and holding you all accountable is because Carrie's belligerence and noncompliance with the law. She withholds information from the public that could prevent us from having to bring it up at meetings. This is why we need ongoing regular patient safety advocate meetings with the board, just not like the first one that was such a fiasco. Question: why are there Spanish versions of the social media posts when none of the information a Spanish-speaking person would click on is actually in Spanish? How is that reaching out to the Spanish-speaking community if you're not also providing the documents in Spanish? What good, then, are the tweets in Spanish? It's just another one of those fake appearance things you guys do to make it look like you're doing your job with public outreach. I have a real problem with the way the panel hearings are set up. Having the same board members serving on the same panels all the time can create a possible conflict of interest. For instance, it was highly convenient that Dev was placed on the very panel that his friend and coworker, who sexually assaulted 4 patients, was having his hearing and subsequently got his license back. The makeup of the panel should be random so as to help avoid that happening. It still astonishes me that no one cares that a 4-time sex-assaulting doctor was given his medical license back, and his brother-in-law is now the CEO of Dev's medical school after donating over $40 million. We're now paying very close attention to who serves on what panel, so I suggest you're all very careful and claim conflicts of interest even if there's just a hint of one. Here's some trivia for you real quick. The discipline of Dr. Frank Fisher took 2,134 days, or 5 years, 10 months, and 4 days, from the time the accusation was filed to the time the decision was filed, and he was only given 3 years probation for an accusation with 39 causes of discipline. It took 2 years longer to process the case than the actual amount of time he has to serve on probation for 39 causes of discipline. And he's a repeat offender. This was his second disciplining. It's nauseating to see you take the time to reprimand a doctor for making a loud noise or for poor record keeping when people are being maimed and killed and sexually assaulted and you're doing nothing about it. Can you imagine what kind of karma that's creating for all of you? Thanks.
Thank you. Are there any other comments on the phone?
Kenwar Gill, your line is open.
Hello, my name is Kamar Gill. Can you all hear me?
Yes.
Okay, the reason I was calling is, I'll get to that, but I'm going to concur with the last speaker that it seems like the governor's office don't look for conflict of interest. You know, the Southern California physician and a couple of his very close financial interests are tied, and those decisions should not be biased based on financial self-interest and personal relationships, and it's something worrisome that we as doctors don't get a fair hearing before the board because we are not able to kind of support those personal self-interests. The reason I called is a separate issue. It was an agenda item 9. I was with the patient. I couldn't speak at the time, but I want to talk about CME, especially as it was listed on the web page. The web page for the CME has undergone several changes since 2009, and it's now more aligned with the ABMS, or American Board of Medical Specialties requirement, which is the board certification, again a trademark. It seems like what Medical Board has listed on their website right now is a copy and a paste directly from ABMS guidelines or requirements. It is interesting to note when David Serrano-Seville was on the board, there was some additions made onto the CME. I think those were regulatory changes, not a statutory changes through the legal process. I don't think any of the doctors sitting on the board objected to it. The addition that was primarily made was addition of a mock as an equivalent of a CME parallel to an AMA credit, and that was something I think was added in the reign and times of David. I'm glad he's out. The second thing I wanted to speak to is I've been in touch with the ACCME president and the CEO, Graham McMahon. He's a physician himself. And I copied that communication to a very senior staff member, name withheld, at the medical board. And what I learned from them is that they've been trying to hold captive AMA PRA credit since 2009. And they were successful in reaching or striking a deal with ACCME and AMA together, bundling those things. And I'll make it simple for the public member of board. Imagine medical board would need a proof of someone visiting San Francisco, and the only proof that is equivalent to an AMA PRA1 credit is a picture taken on Pier 39. So what happened here is ACCME is now controlling all port of entry, the toll plaza on the Bay Bridge, the San Francisco airport, and probably even the ship route to Pier 39. So for a physician to take a picture on Pier 39, he has to make sure he pays ACCME at the toll plaza, and he rides in a car that has been certified and registered by the ACCME. So ACCME has controlled all the routes to AMA PRA1 credit, and they'll pass the cost on to the CME providers, and CME providers are going to pass the cost on to the physicians, and physicians are going to pay for it. What is striking is the last slide, last slide you have.
And the next question is coming from Christina Hildebrand. Your line is open.
Hi there. Good morning. Christina Hildebrand from Voice for Choice Advocacy. We educate and advocate for informed choice and transparency of what goes into your body, being food, pharmaceuticals, air, water, everything that goes in. We want you to know what's in it, and that you can make the choice of whether you want to take that in or not. I had a couple of comments this morning. One of them being with respect to it's interesting for me to hear so many people complain that their complaints have not been followed through correctly, yet when it comes to medical exemption complaints, it seems the board is going out of their way to ensure that those doctors are fully investigated, and any small piece become unturned. So it's interesting to me to hear that the budget is so low and that other much more credible sounding investigations that are actually filed by patients and their families are getting so much more time, or so much less time, and the doctors writing medical exemptions for vaccines are sort of being super investigated. So I'd like the board to look into that. The other thing that I wanted to bring up is we have done several PRA requests to the medical board, and I find it astounding how much the medical board charges for PRA requests. When we do a PRA request to the medical board, we usually do a similar one to CDPH, to HHS, to other entities, school districts, and most of them do not charge us anything. They may charge us for printing, or they may ask us to give them a USB drive so that they can upload it. The medical board charges thousands of dollars for every PRA request we have. And it really, to me, makes it, I'm sure we're not the only people that they're charging, but it makes it much less likely that people get the information they want because they don't have the money. The last one that I asked for was $5,000-$6,000, and I find it amazing that the medical board is allowed to charge that much. I understand that they caveat it with that it uses personnel time and the copying and everything else, but at the same time, every other organization does it for free, or does it for very, very limited amounts, 10 cents a copy or a USB drive. And so I really ask the medical board, somebody mentioned it yesterday, what are you hiding behind? What don't you want us to see? The other piece that I wanted to bring up is that I would also like to see some patient and consumer advocates on your board or presenting. It seems that most of the presentations that are given, and our organization has requested multiple times to be able to give presentations with experts that are experts in their field. But it seems that the medical board really doesn't want to hear from the consumers, who are the people that you're actually supposed to be representing. You're not supposed to be representing the doctors. You're supposed to be representing the consumers.
The next and last comment is coming from Ashley Reeves. Your line is open.
Yes, my name is Ashley Reeves. I'm calling in to ask the medical board what steps they are taking to address the lack of vaccine safety and the risks of adverse reactions and contraindications when physicians are administering these vaccines to our children. It seems like these issues are not being addressed, and we're seeing higher rates of vaccine reactions in children every single day that aren't being reported to VAERS. Doctors aren't trained on how to report to VAERS, and many doctors don't even know that VAERS exists. So while you're sitting here supporting legislation and mandating things like vaccines for children to go to school, or removing children's medical exemptions when they've already been granted by legitimate doctors who have seen them and seen that they've had reactions to vaccines, what steps are you taking to ensure that our children are going to be safe? In addition to that, what steps are you taking to ensure that medical professionals are not discriminating and ignoring the fact that our children are vaccine injured and or denying them medical care because they are not fully vaccinated? You're sitting here on this board and you're supposed to be protecting us and protecting the consumer, and you're supporting legislation that goes against that. So I'm wondering why these things are not on the agenda. I'm wondering why there's so much bias that surrounds parents that come forward and say that my child was vaccine injured. I'm one of them. And we are constantly being under attack, and you are not supporting any of us. So I'm wondering what steps the boards are taking to make sure that my child will be protected and that other children like him will be protected in the future, and what steps you're taking to inform doctors that there is a high risk involved with vaccinating children and the current child vaccine schedule, and educating them better on giving their patients informed consent on these issues.
Thank you.
No further comments at this time.
Great. Let's move to our next agenda item, which is 18, an overview of California maternal health and morbidity rates and initiatives. Dr. Mitchell, please come forward. Thank you. Before she begins, I'd like to talk a little bit about who Dr. Mitchell is. She serves as Deputy Director of the Center for Family Health and oversees the Maternal Child Adolescent Health Division, WIC, and the Genetic Disease Screening Program. Thank you for being here.
Good morning.
Good morning.
I'm pleased to be here and talk to you about what we're learning in California about maternal mortality and morbidity. I am a licensed physician in the state of California. I'm also board certified in emergency medicine. After 20 years of academic practice in the emergency department, I realized that more and more of the issues I was confronting in the emergency department were related to public health and possibly preventable. I took time and received a master's in public health and decided to transition to public health, where I've been working since 2007. So I'm pleased to be here. I see both sides of the issue around maternal mortality. I think my experience and now my leadership role has been very helpful on this issue. We're going to begin here with a slide presentation, and I think that people on the phone, do they have access to it? Does that occur? Okay, great. So I will just indicate what slide that I'm on to help the people on the phone. So this is just a quick oversight of California by the numbers, about 39.5 million people, but we say about 500,000 births annually. This data has been updated recently. In 2017, our birth rate was down to 471,000. Regardless, that's about more or less 1,500 babies a day. So we're very busy in our state. We're very busy not only in terms of families growing and prospering, hopefully, but also in terms of tracking their health and well-being and collecting the data that we need and delivering the service that we need to. We screen every infant that is born for over 80 different genetic conditions and get the results back to the pediatrician within a few days. So that keeps us very busy too, because many of these conditions require early intervention. 96% of our pregnant women get prenatal care. About 43% are insured by Medi-Cal. We are experiencing, as I said, a decreased birth rate in the state of California, an increase in maternal age of first pregnancy, a decrease overall in our preterm birth rate, a decrease in our maternal mortality, a decrease in our adolescent birth rate. So California is doing well, given the size and the diversity of our population. Having well on many measures. But we are experiencing increased morbidity related to pregnancy. We're having problems with increasing, because of the age of having more chronic diseases, increasing obesity that contributes to that morbidity, and persistent disparities in all of our perinatal outcomes. There's so much more that we need to do to address the disparities in both mortality and morbidity and infant mortality and infant health outcomes. And I will be talking a little bit about that. On the next slide, that's titled Births in California from 2000 to 2017. And this slide is showing us the overall birth rate and then the differences by race. It's very simple. So I'm going to move on because I do not want to lose time here. And move right into a maternal mortality. This is a remarkable slide. You don't see slides like this very often in public health or healthcare for that matter. In the U.S., rates of maternal mortality were gradually rising in the early 2000s to a peak in around 2006 and 2007 that had every state worried and paying attention to this issue. In California, just like the rest of the nation, we didn't know what was exactly contributing to this rise. It was about this time that I transitioned from an academic medicine career to public health, and this was put in my portfolio to address the rise of maternal mortality. I think because I was so green, I acted naive and said, well, since we don't know, we need to investigate, and where do we go? And we said, let's start with the medical record. It was as simple as that. We knew the medical record was a rich repository of information. We knew that we had the authority to investigate a major public health concern, and so we went to the medical record to give us information about these women's deaths. This was critical, to view it with an open mind, start where you already had data collected, and then begin to ask some critical questions. What can we learn from reviewing these cases of women who died to understand how that may or may not be contributing? We didn't know, but that seemed like a reasonable place to start. And so usually this is where I stop and then I tell what we did, but I wanted to show you that what happened is that after we started to gather some information and we started to learn that, unfortunately, we all felt bad about this, that maybe the quality of obstetrical care was not what we were hoping it would be. We found through our review committee that there were opportunities to do better. And our colleagues, the providers and the hospitals, were very interested in doing better, and they joined us. We developed toolkits based on our findings that pointed to some changes that could be made both in individual care decisions as well as systemic care. And we did quality improvement efforts. Nearly all of our obstetrical hospitals engaged in those efforts. And because of that teamwork that we had, and we had advocacy groups who were educating women, and we had hospitals and providers and public health all working using every leverage point that we had, our rates started to decline. And what you see on this slide is that the red line is showing that the rates in the rest of the United States continue to rise, while California started to drop. Again, this is a remarkable story for which we've received considerable national attention. So I think what it testifies to is that, first of all, you need good data, and then you need to follow that data into action, and you need to engage multiple partners to around that action. This is a traditional public health model for intervention. Looking at the next slide, titled Maternal Mortality Ratios by Race Ethnicity, though, as much as I'm pleased to take that public health led this effort and that we're pleased to see some improvement, the maternal mortality ratios by race ethnicity are not so good. We have not made a lot of change there. It looks, when you first look at it and you see the red line, which is African American non-Hispanic births, and it looks like, it went up like everybody else and then came down. But I want to point out to you that at the peak, what we call that disparity, what is the line between African American births and white births, that disparity ratio is 4.4. We brought it down some, we brought it down to 3.8, but that is still intolerable. During this time period, that drop in African American mortality rates is around 62%, and for Hispanic Latino Americans, it represents about a 43% decrease. But we really have a long way to go, because you can tell that we've really only returned to rates from the early 2000s or the 1990s. So it's not, while we've brought it down, we have not been able to reduce that further. This next slide, maternal mortality by race, ethnicity, and cause of death. It's a complicated slide when you first look at it, but I will tell you that what it's showing here, when you look along the bottom, the x-axis from left to right, you see the leading causes of death that we found in our investigation. The colors show the deaths per 100,000 live births for each category of race, and then the gray box around each of these represents the disparity ratio. So when you first look at it, you go, oh my, look at that first cardiovascular disease, what a big difference there is between African American deaths due to the cardiovascular disease, which we learned from this committee was the leading cause of death for pregnant women or recently pregnant women. But then when you move across, you see that really what is showing you is that while that looks to be the biggest disparity, really the biggest disparity is where the gray boxes are largest. So it's showing that amniotic fluid embolism shows the greatest disparity ratio, followed by hypertensive disorders at 7.3. So this is just to give you an example of the depth to which we are looking at the disparities, what is contributing to the disparities, where are the opportunities where we might be able to make a difference. The next slide is similar in design in that this is pregnancy-related mortality ratios by race ethnicity, but divided by age. Again, the color schema is the exact same. When we sort by age, mothers greater than 40 years of age have the highest rates of death. And this is also the age group with the greatest disparity between Black and white maternal mortality rates. But you can see, I'm going to show you that this disparity is not just by age, but that it continues across all socioeconomic factors. The next slide divides this up by payers. It's a rough estimation of economic status. This is telling us that it's not just poor African American women who have higher rates than lower income women of all color. This disparity persists despite a change in maybe their income or a change in their education. And this is something that I think that both African American women and maybe their providers don't recognize, that the driver is not socioeconomic status, which it is for many of our issues that are related to social determinants of health. Race appears to be a driver. And it's not race itself. We believe, based on the data that we're seeing and we're learning and talking with subject matter experts, that it's actually the chronic inflammatory state of a high level of toxic stress related to long-term racism and continuing racism that these women experience. And again, another data slide showing you the same information, that even at higher education, we see that these disparities are concerned, persist. So again, I'm going to move on to review what did we do, what have we been doing, and what has been our framework for action. And this triangle on the California PMAR project team, California Pregnancy Associated Mortality Review team, is showing that the Department of Public Health, as I described, initiated the investigation. We took care of all of the IRB needs, the data reporting and analysis, the publications, and then we contracted with Stanford's California Maternal Quality Care Collaborative so that they could recruit and maintain our review committee. They could develop some toolkits based upon our findings, and they could provide consultation and assistance to our hospitals who wanted to engage in a quality improvement project around this. The Public Health Institute helped us to abstract the medical records, and they provided additional data management support. And in the middle was our expert review committee. We could not have done this study for the limited amount of funding we had, and I should mention that we diverted federal Title V dollars to this investigation. The expert review committee committed all of their time as volunteers. These were dedicated professionals throughout the state of California from diverse practice patterns who spent hours and hours delving through the cases and then coming prepared to meetings and then deliberated with one another until they reached consensus about their findings. Again, there's just no way we could have compensated them for their time. It would take, we've estimated that it would be in the millions of dollars. So I can't thank them enough. Moving to the next slide. Based upon these reviews of the obstetrical deaths, we identified that pregnancy-related deaths could be done more accurately through our review process than through ICD-10 coding on the death certificates. Only 70% of the deaths were correctly coded as obstetric deaths on the death certificate, so that this review process was very, very important. We learned that cardiovascular disease was the leading cause of death, and that many of our cardiovascular disease actually occurred late in the postpartum period. This was important because maternal mortality, again, going back to that first really significant slide, reflects deaths within 42 days. But when you think pregnancy-associated deaths go out to a year, and what we were finding is that those deaths out to a year were very important to examine and to look at. People had not given them as much in-depth investigation until now. And then that's where we found that cardiovascular disease, that women were having their cardiomyopathy, pregnancy-related cardiomyopathy, or problems with cardiovascular disease were starting to appear after their postpartum visit. And that became concerning because maybe people drop out of care and they don't have access to the same level of care. As I've said, we confirmed racial disparities were persistent. We uncovered possible contributing factors that led to the pregnancy-related deaths, and we informed recommendations and translational activities so that we could turn our data into action. This next slide, the quality improvement opportunities for obstetric and medical deaths. These were some common themes that emerged. We've published 2 reports about our investigations of maternal mortality, and most recently we just published a 3rd report that was focusing on suicide by pregnant women around the time of pregnancy or within 1 year of pregnancy. So we continue to investigate and monitor and report on a routine basis. But we found in our medical cases that timely diagnosis and reference to standardized evidence-based management was a theme that came up. And this was in regards to some specific clinical conditions such as obstetric hemorrhage, preeclampsia, cardiomyopathy, and amniotic fluid embolism. We found that the recognition and response to clinical triggers was not as good as we'd hope it would be. There would be warning signs such as difficulty breathing or chest pain or an increased heart rate or a complaint of pain or difficulty with estimating blood loss that all led to delayed action in response to the clinical trigger that something was changing in the patient. We found that there were coordination of care issues in regards to hospital transfers, blood banking, moving women to a higher acuity of care. We found that optimal resuscitation of pregnant women was sometimes lacking. I understand that. It's a rare event to have a maternal death. Most of the time it goes really well and you get into the usual routine, and then suddenly when it goes bad, it goes really bad really fast. And so if you're not routinely dealing with that, it's hard to suddenly remember that now you're going from a beautiful labor and delivery to running a code. And as an emergency physician, I know that that's a skill that you can lose pretty quickly. So we were really clear that we needed to have code teams that either responded immediately and knew how to manage these obstetrical emergencies, or that the obstetrical team itself had to drill on a regular basis so that they were ready for these rare events. Because rescue care is critical. These are usually, most of the time, young women, fairly healthy, with excellent rescue care. You hope that it will turn around. But if you're not skilled at rescue care, then your one little opportunity might go missing. Access to care, including timely referrals to medical consultants and subspecialists, was difficult. And maximizing the health of women before, during, and postpartum pregnancy was essential. We found that because of cardiovascular disease being high amongst these women, that we really need to attend to improving the health of women of reproductive age before they become pregnant. We developed several toolkits to transform maternity care. Most of these toolkits that are listed here were developed through the Department of Public Health, but because of the success of this, we were able to engage other partners. So in addition to the toolkit on venous thromboembolism, cardiovascular disease, obstetric hemorrhage, and preeclampsia, we were able to work with the March of Dimes to develop a toolkit around ending early elective deliveries, which had been associated with higher rates of NICU admissions. And the California Maternal Quality Care Collaborative went on and received funding from the California Healthcare Foundation for a toolkit supporting vaginal birth in an effort to reduce cesarean section rates. There are multiple moving pieces. The surveillance is the big yellow one there on the California Primar was critical. Then our investigation and finding led to the toolkits. We worked with private partners like California Maternal Quality Care Collaborative, and then we both engaged with obstetrical hospitals, and then we also have RPPC, or the Regional Perinatal Programs of California, that could have a very close relationship with every obstetrical hospital and could meet with them and identify any barriers or encourage them to be vigorous in their attempts for quality improvement efforts. And then providers. When providers are engaged with the hospitals, they get a lot of support from the hospitals, but I think in order to really address morbidity, we're going to have to think about some other ways to support outpatient care and prenatal care with providers, that their hospital-based experience can be supported by the hospital, but it's harder to find ways to support their pre-hospital. I just have a couple more slides. Everyone asks me, what do you contribute to your decline? And all I can say is that we believe it's a collective impact, that this combination of surveillance, investigation, data that we shared widely, multiple partnerships that we fostered and developed, systems such as the regional perinatal programs, and then we did not blame healthcare providers or hospitals. We engaged them to help us to do a better job, and I think that was a really important role for public health to do, was to make people aware of the problem and then make it safe and convenient for them to then address and try to improve the issue. All of the reports that I've mentioned and the toolkits are available online through the California Department of Public Health, through the Maternal, Child, and Adolescent Health Division. You can search in Google to find almost everything. It's a highly searched item. I want to do a time check. Do I have a little bit more time? Yes? Okay. This is really important because as we transition from mortality to morbidity, for every woman who dies in childbirth in the U.S., 70 other women come close. So let's translate that. I already told you it's a rare event. So about 900 women die a year in childbirth. You multiply that by 70, that's 63,000 women who suffer a severe morbidity or a near-death event. They survive only due to excellent rescue care, but they're very likely to have permanent disability and suffering. So I wanted to share a little bit of information about severe maternal morbidity. Now, severe maternal morbidity is defined by ICD codes, so that you can search through the codes, and we can use our database in California to give us data about what we're seeing. So we know that in terms of severe maternal morbidity among California women that are hospitalized, that we are seeing, as I pointed out before, a gradual rise in all categories. This particular diagram is showing that there is disparities here again in morbidity, just as there is in mortality. And then moving to the next slide. This one is specific to gestational diabetes measures. This is not severe. The other one was severe mortality, where it was a near death. And then this is about a routine kind of occurrence in terms of morbidity-related conditions in pregnancy. There's a break in the middle of this diagram. That's because coding changes and definitions changed. And I must explain that while it looks like there's a rise, the coding change was really important to remember for this slide. It's good to see the information, but it's important to know that the definition went from having two conditions that diagnose gestational diabetes to just having one condition. And so this would have risen no matter what. But the point of this slide is to show you that there are also disparities for Asian and Pacific Islander communities in regards to the incidence of gestational diabetes. This slide is very similar, is showing morbidity for the diagnosis of hypertension among California women. Again, showing a disparity for Black or African American women. And this is the slide I want you to focus on here. I told you that while we have made some progress in reducing maternal mortality, which is the line in the middle of the blue, the line at the bottom, the yellow, is telling us that when we look at mortality by timing, so if we look in the first 42 days after delivery, we are doing better. That means we are having better rescue care, that hospitals are more prepared and physicians are more prepared, and maybe we're anticipating better. But what happens after 42 days, that's the yellow line, is showing a gradual increase. We're hoping it's leveling off, but that is telling us that this is a period of time that we have not previously in epidemiologic research paid a lot of attention to, but we need to, because that's telling us about maybe the underlying condition of the woman, her ability to access resources after 42 days, her intrinsic health, her well-being before she even becomes pregnant. And so I wanted to point this data out to you. Here's a whole list of our maternal efforts that we are going to continue. We continue our surveillance. We're trying to maximize health prior to pregnancy, and there's a list on this slide of some of our efforts. We're improving the birth outcomes for mom with a variety of system changes and quality improvement efforts, and we want to continue to address the postpartum needs of women, and those different efforts are listed for you too. These are our public health efforts around this. So I was asked to conclude with how can the California Medical Board help? I'm not exactly sure of all your levers that you have to be able to pull to help us. These are just some ideas that I threw out. I don't have a lot of experience. That's why I was really honored for you to invite me here today to present to you. But I think that we need to keep influencing improved care by individual healthcare providers, promoting life course theory, which is essentially maximizing the health of girls and women of reproductive age, ensuring that we have good prevention care in pregnancy, like oral health, vaccinations, helping physicians to get pediatricians routinely. They know how to stock and supply and give vaccinations, and this is not really a skill set yet for most obstetricians. Being able to address the mental health needs, ACE screening, that's adverse childhood experience screening, substance abuse screening, depression screening. These are all ways that we can do more to assure that our prevention care in pregnancy is the highest that we can make it. There is some suggestion that one of the factors in our disparities might be that there is implicit bias by providers. There's a lot of conversation about that. I think what's really important, though, is that if we do believe that that may be a factor, that we develop training or processes or programs to address it for which we have evidence of their effectiveness. We need to encourage referrals to the many social services that we have that are available to vulnerable women, and we need to continue value-based incentives based on perinatal outcomes. And we need to support advancement of systems of maternity health care, support regionalized maternity care, which is important for disasters, inter-hospital transport agreements. We need to monitor the quality of maternity care and support the maternity quality initiative efforts that are already out there. And we need to continue to increase the partnership between the hospital and the community, really looking at how can we better use the community benefit program or the community building program, and connecting with the community, thinking about local birthing centers, doula care, transportation and childcare needs for these women. So there's a whole variety of ideas. I really thank you for the opportunity to present some of our data and some of our work and to engage with you today. Thank you.
Thank you. That was very eye-opening. Very good presentation. Glad that California is improving on this issue, especially when it comes to Black women, as being a Black woman myself. I'm really concerned about this issue across the country, not just here. And I think you've done a really thorough job on really honing in on the variety of issues that's causing it. So, obviously, racism being one of them, but not the only thing. And I think that was important to share, and I think you did a really good job in the time frame that you had to share that with us. So I'm going to open up to see if there are any of my colleagues that have questions. Dr. Krause and then Dr. Hawkins.
You may be too modest, but I'd like to view California's success as coincident with your taking the job, and thank you for your efforts. But I also want you to realize that your invitation to speak is just a way of our sucking you in. And we would look forward to a continuing collaboration. And you're quite right to wonder what our levers are, because every state agency does have some limitations. But I'm a true believer that when we have agencies collaborating and working together, that we'll be much more effective. So most of our physicians receive our newsletter and read our newsletter. So part of it should probably begin with information pieces in our newsletter regarding this epidemic of maternal mortality. Additionally, obviously we're responsible for licensure and discipline. If there is some way of you perhaps reviewing some of our expert opinions on obstetric cases gone bad, and to tell us whether or not our experts in obstetrics are the right experts for us, and whether or not we should broaden and strengthen our obstetric experts who review complaints, that could be helpful as well. And certainly we're active with the legislature. So some of the things you describe in terms of things that we might be able to do are clearly things that would require legislation. So if you could collaborate with Jennifer Simoes and our board as we begin to think of things to bring to the legislature, that could be very helpful as well. So thanks for coming here, but we're looking forward to a long-term relationship.
Thank you.
Dr. Hawkins? And
yes,
then Dr.
again, thank you for this comprehensive, complicated review, issues that are important to all of us. Too many questions I asked, so I'm going to limit it to a few. What is the trajectory of the statistics? I know that the analysis is ongoing, but I saw that some of the most up-to-date data ends at 2013 or 2015. Yes. In general, the trajectory of some of these conditions. I was intrigued by this chronic inflammation, racism piece and how you ferreted that out. And finally, just the impact of insurance. I thought you said about 40% of the care is from the Medi-Cal sphere. I take care of Medi-Cal patients. I'm a primary care physician, and sometimes we have real issues with referrals, and I don't want to monopolize, but just your thoughts briefly on this.
The first one on the data. We added in 2003 a checkbox on the death certificate that asks, was this woman recently or currently pregnant or recently pregnant within the last year prior to the death? And we found through our case review that there was not good alignment between that checkbox and the data in the medical record and then the data in the death certificate. So we were able to substantiate and validate the data through 2013, and then we found that there was something that was happening in the death certificate where it was becoming even less reliable. The checkbox was not used according to the guidance. We're remedying that by changing the death certificate, but we're also remedying it because we have to go back, unfortunately, to every of those deaths, confirm, actually do a chart review for all of the death certificates that were reported as pregnancy associated and confirm those. So we're having to do a lot of additional work. We hope that will be fixed when the death certificate is fixed, which should be in about 1.5 to 2 years. In the meantime, we're going to be incorporating a different methodology from the CDC. It's not ideal, but we think it'll be a good approximation. From my preliminary look at that data, we've leveled off, and we're watching it very closely to make sure that we don't go back up again. In regards to your question about the inflammation and racism and all of that, you're totally right. I think somebody else mentioned this too. It's not the only issue, but we are seeing physiologic links between elevated cortisols, hyperinflammatory states, particularly like for the example in preeclampsia, where the placenta itself it changes biologically. It becomes more inflamed. It might be linked to preterm birth. It might be linked to preeclampsia and eclampsia. So that's what I was referring to, is that this high chronic cortisol, hyperinflammatory, now having biologic changes that may be then linked to pregnancy outcomes. Does that help? And I'm sorry, your last question?
The quality issues that you mentioned, and there are numerous ones, those are the impact of insurance. I thought you said about 40% of these deliveries are Medi-Cal.
Right.
And as a Medi-Cal provider, I have issues sometimes with referrals for not so much getting to the obstetrician, but chronic medical problems, getting to the cardiologist, the nephrologist, et cetera. So the impact of the Medi-Cal, the insurance on these mortality.
That was one of the things that I think that the more that we can do to create systems of change so that referrals are easier and that you can elevate the acuity of care much more easily, whether it's to a specialist or to initiate an inter-hospital transport, I think those will be essential for this. So I appreciate your comment, but I think we have more work to do in making it easier for everyone.
Mm-hmm. Dr. Yip?
Thank you. For the non-physician member, I think this is one of the most successful improvement we have seen in public health in the last 20 years. Mm-hmm. Congratulations. So question, I think you have collected and see the data disparity as far as count is concerned. And also, I'm glad you effort in the prenatal care that looking into cardiovascular. I think in the private practice, you see weight, BMI, diabetic, a lot of influence in the outcome of the M&M. The other question I have is that with the change in immigration status recently, there's a story that patients undocumented, even documented, they are not willing to go to prenatal clinic. Do you see is something going on? Will you see a rise in the M&M again because of that? The other question I have, you also involved the data as far as licensed midwives in the collection of the delivery data and M&M too. Thank you.
I'll start with your last one first. We had both, we had representatives from midwifery organizations that were very involved in our review process and very engaged, and also contributed to the development of our toolkits. They were very integral to the process. In regards to immigration status, we're lucky in California that we are able to offer emergency Medi-Cal to women and notwithstanding whatever their immigration status is. That's similar for WIC too, by the way, which is why a WIC referral is so important. We are watching very closely our data to see if we see any kind of trends in women dropping out of care or services because of certain climates or new positions around immigration. So we're watching to see if what kind of influence that actually has on behavior. So that is a very good variable that you brought up.
Ms. Friedman.
Very much. That was so informative, and thank you very much. It was incredibly informative. And I have a few questions. When you hear the word maternal mortality, most people think of it, death in childbirth. So when you said up to 42 days and sometimes up to a year, you changed my thinking about it, because I think most people think it's definitely during childbirth. Mm-hmm. Can you separate out that particular part of it for us? What percentage of it is actually during childbirth? And secondly, with Dr. Krause's suggestion about legislation, definitely this is a place where legislation could help, I think. Mm-hmm. And if you had a choice of like one or two things that you absolutely think we need to put into legislation, what might those be?
First of all, in regards to, we divide maternal mortality into early and late, and early, as you correctly described, is up to 42 days postpartum. And the preponderance of those deaths did occur to lump towards the time of the delivery. So there's a big peak there, and then it drops down to 42 days. And we have that, we have graphs and data on that in the report that's online. I don't have the exact numbers, but the majority of it does occur at childbirth, like you first said. But then there's that peak that occurs in late maternal mortality that's very interesting. So what's happening to those women that you think they're okay, they made it through 42 days, they went to their postpartum visit, and you think everything's great, and then they have a terrible event and die. And that's a group that we need to focus on and learn more about. In regards to legislation, I work in the executive branch. We can help provide technical assistance on any kind of legislative proposals or ideas, but it's not mine to suggest ideas, but we can provide technical assistance when those ideas come forward, and those would be directed to our Office of Legislative and Government Affairs.
Okay, I'm going to go down this way. Dr. Gananadev.
Thank you. Dr. Mitchell, thanks for coming. Just important information, even though just worries me that it stopped at 2013 or somewhere. It's still about 5 or 7 years behind some of it. So, but one thing which puzzled me was the mortality among Hispanic and African Americans. There was a significant difference, and Hispanic mortality was close to white. So what is the reason? Can you think of? Usually in many other diseases, when we look at race versus mortality, there is significant. The Hispanic Americans are somewhat closer to African Americans rather than white or Asian. So I'm just curious what that is about. Why you think?
So I want to make sure I understand. Your experience is that with Hispanics that they tend to have lower? Are you referring to like what they call the Hispanic paradox, where it tends to be better health? Or?
No, their mortality rate in many other diseases are significantly higher than the white and closer to the African American. Here, in this part, Hispanic Americans' mortality is significantly lower than the African American and closer to the white people. So I'm just wondering why that is.
Yeah, I think we're kind of in a way talking about the same thing, because it appears that that there is a benefit to the Hispanic or Latino-X culture, and that when they first come to this country or even born in this country, they tend to be a little healthier, maybe strong family connections or cultural practices. There's a lot of literature on that. And so we're dealing with, in the case of maternal mortality, mostly young women. But then this disparity starts to increase over time, as there's enculturation or time spent here or something changes with that population. And so then you're right, it may be higher later in life, but in this particular population of young women, that we don't see the disparity.
And the late mortality you mentioned, which is extremely important. So have you done the racial distribution about the late mortality? What's the difference between different races?
I showed some of the slides that I showed around morbidity are similar to for late mortality. And that cardiovascular disease is the #1 cause of the late maternal deaths, and there is a persistent disparity where African Americans really exceed those of white or Hispanic.
Okay, thank you.
You're welcome.
Okay, Dr.
Thank you so much for this wonderful work. I was just wondering a couple of factors. This study kind of stops around 2013. Have you thought of doing more data analysis since Obamacare came into effect? Like after that, a lot more people got medical care and other care, and that might have made it even better. #1 point. And I think that'll be a good thing to work on so that we can work in California more to get everybody access to healthcare. #2, have you seen the studies comparison between people living in inner cities or real urban areas and people living in really rural areas? Because people in urban areas are going to be more with comorbid conditions like heart conditions, other stuff, and whereas people in rural areas will have more problem with access to healthcare, going to hospital, going to practitioner or anything like that. That would be really a good parameter to tell us how can we improve this further.
Thank you. You're right about the Affordable Care Act being a major change, and there was increased access to care in California. So as we begin the study of that period, that next time period from 2013 onward, that will definitely be a variable. I will say we did find that there was already a little bit of difference between urban and rural, and again, it comes around access to care and specialty care, and services in the rural area were harder, and interhospital transfers were sometimes delayed, time and transportation, so we are already seeing some differences, but that's an ongoing variable that we look at.
Great. Yeah.
My question is quick because you almost left a little roadmap for us. You were saying that good data and then taking the action probably from that data, and in this partnership was the kind of the methodology that you followed. Can you explain that a little bit more to me? Because that was like what I found the foundation for how you approached the problem and then came to all of the solutions.
Right. And that transition, that critical moment where you can look at the case and you can understand what's happening, and then we asked our committee to go one step further, and we said, what do you think were the contributors to the deaths? What were things that happened in that case that you thought was critical in going from one path to another? And then we asked the second question. So we were able to identify contributors and themes. And then the second question we asked of our committee was, did you see a specific quality improvement opportunity where if you would have done something different at that point, that you might have been able to get back on the path of surviving? And so that was an unusual thing to ask the committee to do. Unusual in that we were one of the first in the country to do that, is to take their expertise, their experience, their commitment, their resolve to understand this, and then ask them to go one step further. Because then if we had an idea of the contributors, and we had an idea of where opportunities to actually do something different lie, then we could then develop these guidance documents and toolkits and resources that could be put to immediate use. And I think that was what was critical, is when our partners in healthcare, providers and hospitals, saw that we were trying to give them a pathway and give them the tools and resources, they jumped on board and were willing to engage. I know a lot of people don't like to engage with the Department of Public Health and parts of us, but they were very willing to engage. And we used the California Maternal Quality Care Collaborative to create a little space between the Department of Public Health and this effort around quality improvement. So they acted on our behalf in a more private way, helping them to institute quality improvement changes, and then giving them more real-time data. They were able to get some of their OSHPD data right back to them about the changes that they were making. So that became kind of an offshoot of our efforts, so that they would not be so afraid to interact with the Department of Public Health, interact with the Maternal Quality Care Collaborative, make a change in their hospital, get data back right away on how they were doing with that change, and do so knowing that the total commitment was on improvement of care, not blaming anyone.
Great.
Did that help?
Oh, that helped a lot, because that partnership transformed the whole process.
Mm-hmm.
And that's pretty ingenious. Thank you.
Ms. Lawson?
Thank you. What an incredibly informative and just important conversation for us to be having. And I think what I wrote down as you were speaking, and Dr. Hawkins referred to it also, was this concept of a chronic inflammatory state or toxic stress that's sort of maybe leading, right, or maybe correlated to some of these bad outcomes over time. And I guess a couple of questions sort of along those lines, which is one, what are we doing in California? What's the Department of Public Health doing to sort of address that more long-term condition that frankly starts when these babies are born, long before they become mothers eventually? And then two, kind of a separate question, which is, our results here in California are good. What are we doing to export what we have learned here and be a thought leader in this space, nationwide and internationally?
In regards to the disparities, there are multiple contributors that's been mentioned. The social determinants of health, the communities in which people live and grow and learn and pray and play. But also, we have data that shows that African American women, pregnant women, we do an annual survey through our maternal infant health assessment, that they routinely report much higher levels of experiences of racism that we've been able to associate with with poor health outcomes. So these experiences of racism, there are tools for measuring it. And so we decided that we needed to start there. We needed to start with women, make them aware of their risk, introduce them into this concept of the chronic toxic stress of racism. And we started our Black Infant Health Program that's designed around that. We fund the counties that have over 90% of African American births to have this very intensive program for them. And then we have wraparound supportive programs through the Perinatal Equity Initiative that helps them in accessing care, and there's a fatherhood engagement component, there's a preconception care component. And so we believe that right now we have a model that we can test and evaluate to see if this is going to help us.
And sorry to drill down on that, when you're looking at that racism, you're looking at racism in the healthcare system or in the, forgive me for being a public member, in the healthcare system specifically as it relates to their pregnancy, or broader?
No, we're looking at we know that all of the experiences of racism are probably likely contributing to their higher risk. And so there may be pieces of that. And as I mentioned before, that the healthcare system is looking at that to see, what might be their role and what could they do about it, but we're looking at it as a conglomerate. We also use the life course theory. It's very important to us. The life course theory tells us that you can start off as an infant And then you start a trajectory of life, and part of that is, your genetic makeup and, your basic health at the time of birth. But then there's an accumulation of either risk exposure or resiliency, protective factors. And then those things working together, your risk exposure and your resiliency, kind of work along in your life, and it leads you down your health trajectory of either being more or less healthy. So we really like this framework for describing how more kind of upstream early childhood, ensuring that children thrive and are as healthy as possible, and that young girls and women are as healthy as possible prior to becoming pregnant. We think all of that is an important investment at the beginning. Life course theory also helps us to understand disparities, because life course theory says that if you have more risk factors and less resiliency, your health goes down, and vice versa. If you have more resiliency and less risk exposure, then your health is likely to be better. And then that leads to these diverging lines along the life course. Finally, around the role of leadership, we have been nationally and internationally recognized for our work. I just recently returned from Washington, D.C., where the state of California received a prestigious award from the Health Resources Service Administration for our leadership in this regard, the Vince Hutchins Partnership Award, because we've influenced partnership. And we've influenced it. It doesn't matter how large or how small an organization is. If everybody is working together in their lane, they can influence this major health issue. We were privileged to inform before the Obamas left office. Michelle Obama asked for a White House briefing on this issue, and we were able to inform and provide our data, because the question was, what is California doing, and can the rest of the nation? This has influenced federal legislation around maternal mortality, some new resources that have come down that were not there previously. So yes, California is leading on this, and again, you made a kind statement. It's not me. I was just the person who said, let's everybody jump on board, and I welcomed everybody to help us, large and small. The point was to move ahead.
Great, thank you. Dr. Kraus? And then, okay.
What is the data on VBAC?
In what regard?
Maternal mortality.
Oh, how does it contribute to
Or
maternal mortality?
is it a significant factor? Is it a health risk? Does the Department of Public Health have any concerns about VBAC?
I would say I would need to get back to you on that. We did look at cesarean section in our work, and to try to see if that was a contributor. What we knew was that while the first cesarean section may not have been a risk factor for mortality, a second cesarean section was. And so one of our recommendations was to do everything possible to prevent that first cesarean section. So I know that's not an exact answer, but I just don't know in particular if there was data in that report on VBAC.
It'll be helpful if you can look at data, because even though we voted yesterday not to be the sponsor to bring forward legislation that would necessarily make it much more difficult for a woman to choose VBAC by not allowing licensed midwives to practice VBAC, I'm confident that some organization or another will introduce legislation in 2020, and it will become a subject of discussion. And one of the things I learned yesterday is sometimes we want to make a decision, but we don't have the data for that decision. Mm-hmm. So if your department could look at the data in terms of VBAC outcomes, that'll be helpful in 2020 if this comes to legislative effort.
I know that in that toolkit to promote vaginal birth that there was data in regards to this. I just don't remember it right now. I just remember the important data around cesarean section.
I have a question. Going to cesareans, are you seeing more cesareans with women of color as their first delivery?
There was a little bit of an indication of that, or we're seeing that. So that's not the maternal mortality data. So you're asking me about some other data that I didn't come prepared to discuss in such detail.
That's fine.
Yeah. but I think that we were seeing a little bit of a disparity around that. Definitely, it was really interesting, our work around improving or trying to reduce elective delivery. There was some real interesting findings around that there were that women thought that it was okay to induce an early pregnancy. They thought that it was safe to do. We had the science to do it, and let's just get this baby out and let's just do it. And some of those ideas about what is safe or not safe to do vary among the population. And so part of that effort was to let women know that, no, you want to keep this pregnancy as long as you can. It's better for you. It's better for the baby. And I think there's some of that misconception around cesarean section that it's not the modern thing to do, that it has risks associated with it.
Okay. Dr. Hawkins and then Dr. Thorpe.
Yes. Thank you again for your thoughtful responses to our question. This is probably also beyond the scope of, but I would like to know, and maybe it's a different topic entirely in a different day, the neonatal outcomes. Who's studying that? Who can tell us about what happened to these babies that were delivered? Did they die? Did they deliver? Were they low weight? What about that data?
The babies of mothers who died?
Yes. Increased morbidity.
Most of these deaths were, again, around the time of delivery, and most of the children were safely delivered through an emergency C-section. Certainly, we had a lot of motherless children left behind.
Dr. Thorpe?
Thank you again. I think everyone is very impressed with the quality of the data and the quality of the presentation. It was really helpful. My question really is related to the late complications. One of the things in primary care and in maternal care related to these diseases, cardiovascular disease, hypertensive cardiovascular disease, etc., is related to not only lifestyle but pharmacology and the availability of certain medications, which often is a challenge in the Medi-Cal population, being able to get the same types of medications consistently across the spectrum of care for a long period of time, or a long enough period of time to be effective to help improve blood pressure, heart function, etc. Do you see that as an issue? Is that something that you've had a chance to look at, or?
Yeah, the late maternal deaths, we have not been able to do the intense investigation because that's, again, pulling those records and looking at them. But I've made a note of your suggestion around pharmacology availability and choice of pharmacology, and I appreciate your comment.
Okay. All right. Thank you so much, Ms. Mitchell. Yes. We really appreciate it.
You're very welcome. Thank you.
Sure. Can Sarah Davis please come?
Hello, Sarah Davis. I'm a licensed midwife. I also have a master's degree in maternal child health systems, and my work there is basically entirely in this issue, specifically the perinatal outcome disparities by race. And so I wanted to direct you all to a couple of amazing resources. One would be and perhaps they would be possible speakers in the future, and that would actually answer a lot of the questions that you had today. One is the Black Women Birthing Justice, which is an Oakland-based organization. They actually published a book specifically about Black women childbirth experience in California called Battling Over Birth.
Could you repeat the name of that again?
Yes, Battling Over Birth, Black Women and the Maternal Health Care Crisis in California. They have the full book available, but they also have an executive summary that you can download for free on their website, and it includes recommendations to policymakers, and they have like a very brief outline piece that I'll just read right now, and then quite a bit more quite a bit more detail, but recommendations for policymakers outline is A, address barriers to access to and persistence with prenatal care by Black pregnant individuals. B, expand options for Black pregnant individuals to include midwife-assisted birth center and home birth as viable alternatives. C, establish mechanisms to improve accountability, patient satisfaction, and best practices in relation to labor and delivery. Another resource is the Listening to Mothers in California study, which was a very large study done by the California Healthcare Foundation, again, specifically California mothers. And they've been interviewed after childbirth in California about their experience and what providers they had access to. They overrepresented Black women in the sample, knowing that there's all of these issues that we need to look at. And they show that Black women are overwhelmingly getting more medical intervention that they want and more than is medically appropriate. And at the same time are not being listened to when there are triggers that should indicate that they get better care. So I think one example, and I know we've talked here in this discussion about the chronic cortisol, toxic stress burden being an issue, but implicit bias and explicit racism also definitely occurs in prenatal care and childbirth. So a great example of that is across medicine, Black patients are considered to not experience, like their complaints of pain are not taken seriously compared to white patients. So when you look at this presentation, for example, things like chest pain, saying I'm bleeding too much, these kinds of things, when they're not taken seriously by a Black woman, that Black woman is more likely to die. And that is explicitly why we're seeing that increased mortality from things like AFEs or PEs or et cetera. Okay, so those two resources, I can give you those written as well. I would encourage you to take a look.
Thank you.
Quick question. Who did the Listening to Mothers in California study?
California Healthcare
Foundation.
Thank you.
Are there any other comments in the audience?
Yes, hello. Hannah Reed, Dr. Reed with Black Patients Matter. So I just want to point something out. So the board member who brought up the question about, why is it that the curve with the Hispanic approaches that of the white patients and not the Black? So the fact that he didn't know the answer to that, what is that called? What is it called when a person categorizes Hispanics as non-white? Why did he have to ask that question? So I point this out to you because when it comes to the definition of race as recognized by the state and the U.S., there's only about, 3 races? Black, white, Asian, okay? And Hispanics is not a race. Hispanics, if we were next to Germany and, we had all these issues, the Germans would still be white. Okay, so I was there other folks that were surprised that the curve of the Hispanics approached that of whites? Well, no, it's expected because Hispanics are white, unless they're not. That's how it's categorized. So that was that question. So the fact that, that statement was made, the question was asked, what is that called? What are we calling that? Bias, implicit, misinformation, not knowing, ignorance. I don't know. I'll let you all define that. So let's go back to this. So we saw a wonderful, wonderful presentation by Dr. Mitchell. I can only imagine all the training and experience and the learning and that she brings with her in this part. But I would say, as I looked at it, and I think there are several others in the room as we looked at it, there was a missing data point. There was a missing category. And so if I saw it and others like me saw it and the rest of you didn't, what is that called? Why is it chronically elevated in Black patients? So we're pointing to this high cortisol level and all this stuff. What was missing? So one of the board members mentioned about California being the thought leader and we want to, lead the country sort of thing. Okay, I've got it. I've got the answer. You've got the answer. And if you don't have the answer, what is that called? Okay, so here's the thing is, the one category that I wanted to see up there that I didn't see was when we look at African American patients that were there, I would have expected to have seen which African American patients had a black doctor or a non-black doctor. That would have been very important. And then also, the solution is very simple. If we're talking about chronic inflammation, this is nothing but white trauma. So all you need to do is hire more black doctors and nurses. That's all you need to do. That's the missing link. Thank you.
Thank you. Are there any other comments in the audience? Any comments? Oh, come forward.
Faith Gibson, mercifully short. That the VBAC issue starts with the contrast to the repeat cesarean. That repeat cesareans are more problematical than the primary one, and the more of them that are done, the more the problem increases. So it's not just the statistics on VBAC outcome; it's also as contrasted with doing repeat cesareans. Thank you.
Thank you. Are there any questions or comments, rather, on the phone?
We have two comments from the phone. Christina Hildebrand, your line is open.
Hi there, Christina Hildebrand, the Voice of Choice Advocacy. I just wanted to give you two other references or places to go. Oakland is the place to be, I think, for the Black African American issue with the high birth mortality and morbidity. Another Oakland-based foundation is the Oakland Better Birth Foundation, and they have also written there's a book available called Birth, A Black Woman's Guide to Surviving and Thriving. I think what you'll find is that midwifery and doulas are incredibly important in the African American having better outcomes. And I think, it's interesting that this comes up with the whole discussion on midwifery because it absolutely is tied to this. You will see, and I was actually surprised too that there wasn't more in depth in the presentation on why African Americans and blacks are don't have or have a much higher morbidity and mortality rate, and why that wasn't dug into here. That seems to be a huge issue in California, and something that's tipping us in the other direction. And so I do think the midwifery side of things and having doulas and having the support there is really, really important, and the VBAC issue comes into that. So, I think it's interesting that all of this is being discussed in the same board meeting, because I think you should be tying all of these pieces together, and you'll see that you actually can have better outcomes with the Black women being supported by doulas and midwives and home births and all of that type of thing. Thank you.
Thank you. Next.
And the next comment is coming from Eric Anders. Your line is open.
I'm reading this on behalf of Marion Hollingsworth, who's out being an active patient safety advocate this morning. Marion wondered why you would have a report on maternal mortality presented at a medical board meeting. Boards don't prevent deaths. They just review the doctor's action after the death occurred for the grieving family. Did you want this presentation in response to Charles Johnson calling you out last year when he spoke about his wife's death and the doctor's pitiful discipline to make it look like you care? The issue that should be presented to this board is its track record for allowing doctors to continue practicing after they have been found responsible for the death of a woman in childbirth. Your track record is dismal and frankly dangerous. Under this board's own disciplinary guidelines, any doctor found responsible is supposed to get a minimum of 5 years probation. Yet the doctor who dismissed obvious signs of Kara Johnson bleeding for 10 hours and was given just 4 years probation. And he had more victims. Your own documents show that this doctor had severe bleeding issue with 5 more patients. One of them coded in the OR but was revived. This doctor is still delivering babies. Another doctor was given just 35 months probation after a new mother bled to death under his care. This board had given him 5 years probation, but he complained that the discipline was too severe. So you gave in. You have another maternal death case pending from 2013. What is taking so long? There is no excuse for allowing a dangerous doctor to practice unfettered while a grieving family raises a motherless baby and waits for more than 6 years for you to act. There is also the death of a baby from 2013 that you have yet to decide on. All these doctors are still practicing. If you want to make more of an impact on maternal mortality in this state, you have to act quickly and decisively to take these dangerous doctors out of commission before more women die unnecessarily. Stop trying to keep them in practice. Be more concerned about the women and their babies. This is your job, to protect the people of this state. Is CDPH aware of how the medical board is enabling these bad doctors who are harming women of color? I suggest Dr. Mitchell watch our video of Charles Johnson from a year ago when he explains how this board let him down on this issue, and study how the board isn't following its own guidelines and public protection mandates to protect bad doctors. The medical board is hindering this process. Thanks.
Thank you.
No other comments at this time.
Great. Let's move to our next agenda item, item 19, update, discussion, and possible action of recommendations from the Midwifery Advisory Committee. Ms. Breglia.
Hi, thank you. So the order of this is requested action and then background. I was wondering if I could do background first.
Sure.
Okay. So our last MAC meeting, Midwifery Advisory Council meeting, was held on August 22nd. At this meeting, the following actions were taken, and we were provided with the following information. We created a task force to begin the process of revising the midwifery guidelines, which need updating and to be brought current. We created a task force to investigate problems that parents are having obtaining Social Security cards and filing birth certificates for their infants born out of the hospital. We created a task force to investigate issues surrounding Medi-Cal. We discussed adding the ethnicity of midwifery clients to the licensed midwives annual review statistics, and discussed establishing goals for the MAC and what our ongoing direction should be. We received an update on midwifery legislation, an update on the midwifery program, and received an update on the licensed midwives annual report. So, after review and consideration, we request that you approve the following agenda items for the next Midwifery Advisory Council meeting. We'd like to continue discussing establishing goals for the MAC and receive our update on midwifery-related legislation. The task force on Medi-Cal-related issues would like to give a report, as well as the task force on revision of the guidelines for midwifery practice. There is a report from the task force regarding challenges obtaining Social Security numbers and electronic filing of birth certificates. There's a presentation from the California Association of Licensed Midwives survey regarding physician refusal to provide care for the clients of licensed midwives. The report from the council chair, an update on the midwifery program, meeting dates for 2020, and discussion on the data collected on the licensed midwives annual report. Additionally, in light of yesterday's agenda item regarding proposed midwifery legislation, we would like to add an additional item on the agenda to allow discussion of next steps towards resolution of the issues preventing regulation and implementation of AB 1308.
Great. Can I get a motion
So
to accept it?
moved.
Great. Are there any questions or comments from members? Are there any comments from those in the audience? Go to that one.
Yes, so I first of all want to apologize for my outburst. It's a very emotional topic for me. So I'm going to say it. I don't know. And I of course, I don't want to hurt anyone's feelings. I always say that to folks, even when I sue them. So I really don't want to. But what if the solution is this? As far as the ongoing healthcare disparity and the work that you do, of course, is very important. But what if the solution is we have to replace our leadership in this area with maybe not African American individuals,
Ms. Rhee,
but
this
black-minded?
topic is on agenda items for the Midwifery Advisory Council.
Right. So in her advisory council recommendations, it was wonderfully done. I agree with all that she has said. My statement, my response to her presentation is that we at Black Patients Matter would prefer seeing someone who has had background training and exposure to African American patients, is black-minded, and that sort of thing. So I just want to say that. So thank you.
Are there any additional comments in the audience? Any comments on the phone?
No comments from the phone at this time.
Okay. Ms. Cruz-Jones? Oh, Ms. Freeman?
I have a quick question.
Okay.
Did you say that one of the things you were interested in having us deal with is physicians refusing to supply care to a patient if a midwife was used?
Yes.
And are there numbers on that?
There are, and we will be receiving a report based on a survey. But from my personal experience and conversation, almost every midwife has had problems with being able to refer a client for medical care when we deem that the client no longer falls within the normal range and needs additional medical care.
Okay. Ms. Cruz-Jones?
Ms. Friedman.
Yes.
Dr. Gonadev. Dr. Hawkins.
Yes.
Dr. Kraus.
Aye.
Ms. Lawson. Dr. Lewis.
Aye.
Dr. Mahmood. Dr. Thorpe.
Aye.
Mr. Warmoth.
Yes.
Mr. Watkins.
Aye.
Dr. Yip.
Aye.
Ms. Pines.
Aye. Thank you.
Thank you.
Let's move to our next agenda, item 20, discussion and possible action to amend Title 16 California Code Regulations, Section 1364.10, and repeal Section 1364.11 regarding citations and fines. Ms. Webb.
Members, please turn to agenda item 20, and this is regarding changes to the regulations on citable offenses. And as you heard during the presentation yesterday, the medical board has a long list of citable offenses. Staff recommends changing the structure of these regulations to remove the list of citable offenses and permit the board to issue a cite and fine and/or an order of abatement for violation of any statute or regulation which would be grounds for discipline by the board. This will alleviate the condition of the list being perpetually outdated. That happens because statutes are added, statutes are repealed, same with regulations that are referred to in this particular regulation. With the proposed elimination of this list, staff also proposes consolidating the remaining provisions from Section 1364.11 into Section 1364.10. This will result in the repeal of Section 1364.11 and reduce our number of regulations, make our regulation book less heavy, and I think be streamlined and easier to understand. Additionally, staff updated the language to refer to the amount of the fine authorized by Business and Professions Code Section 125.9 rather than specifying figures in the regulation. Again, this way, when the fine authority changes, the regulation will still be current and we won't have to go through this rulemaking process, which is quite laborious and time-consuming. There's other minor changes to the regulations. An example is you might see through statute that the legislature is changing the phrase his or her to their, and we are going through that process when we're working on our regulations as well. So I'm happy to answer any questions you may have.
Dr. Hawkins?
So I'm not sure if I understood correctly. Will we be vulnerable to a physician who says, well, that wasn't on the list? I didn't realize that that was vulnerable to a fine or citation because it wasn't on the list of...
Under the current structure, the board couldn't issue a cite and fine or order of abatement if it wasn't on the list. And so it just, these are for cases where there's not going to be another action taken. It's not going to go through formal discipline because we might not be able to meet that burden of proof of clear and convincing evidence. But for cite and fine, it's preponderance of the evidence. And so there are situations that a cite and fine would be appropriate, would help educate the physician, bring that physician into compliance, and also alert the public. But if it's not on that list, it's not going to happen. We want to eliminate those gaps.
Dr. Kraus?
I'd like to move to direct the staff to prepare the necessary regulatory documents to submit to the Department of Consumer Affairs and the Business Consumer Services and Housing Agency, and upon DCA and agency approval, submit the documents to the Office of Administrative Law to notice the proposed regulatory language to amend Title 16 of the California Code of Regulations, Section 1364.10, and repeal Section 1364.11, and that we authorize the staff to make non-substantive changes to the language and respond to non-substantive comments during the rulemaking process without returning to the board.
I second that.
Are there any comments from any other members? Any comments from those in the audience? Any comments on the phone?
No comments from the phone at this time.
Ms. Cruz-Jones, please call the roll.
Yes.
Dr. Gonadev? Dr. Hawkins?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson? Dr. Lewis?
Aye.
Dr. Mahmood? Dr. Thorpe?
Aye.
Mr. Warmoth?
Aye.
Mr. Watkins? Dr. Yip?
Aye.
Ms. Pines?
Aye. Okay, moving to agenda item 21, discussion and possible action to repeal Title 16 California Code of Regulations, sections 1357, 1357.1, 1357.2, 1357.3, 1357.4, .5, .6, .8, and 1357.9, and sections 1357
Adding.
and add sections 1357.10, 1357.11, .12, .13, .14, .15, and .16 regarding the Physician and Surgeon Health and Wellness Program. Please continue, Ms. Webb.
Again, this is agenda item 21. And most of you will recall that the legislature authorized the board to develop a physician health and wellness program for physicians with substance abuse problems. The board asked staff to move forward with developing the regulations to implement the program, And staff held 2 interested parties meetings and prepared proposed regulations that were approved by this board. As the rulemaking package was moving through the review process, meetings were being held to change the terms of the uniform standards for substance abusing licensees, which are the foundation for the board's PHWP, Physician Health and Wellness Program. The authorizing statute requires the PHWP to be consistent with the uniform standards. In anticipation of changes, and in light of the onerous multi-level review process that rulemaking packages go through, staff recommends changing the structure of the proposed PHWP regs at this juncture. Otherwise, every time there is a change to the uniform standards, the board may have to submit 2 rulemaking packages, one to change our uniform standards that are currently in our regulations, and the other to change the PHWP regs. At the time when these were developed, the idea was that it would be all encompassed, so people wouldn't have to flip from the PHWP regs to another part of our regulations. But it's just doesn't seem like that's going to be a good idea. And so we want to adjust it at this juncture. This new language that you see here refers to sections already approved in regulation where possible. So instead of laying out the terms again, it refers the reader to regulations regarding, for example, biological fluid testing or the requirements for testing sites and laboratories. The hope is that it will make the review process for these regulations easier. There's, given the multi-level review, there's a lot of ideas on language when we have to comply with the uniform standards, but it's hard for people to understand that the language isn't going to change and unless there's a formal change to the uniform standards. So this will just hopefully streamline it. And it will reduce the need for rulemaking in the future on 2 packages each time. So the other part to this rulemaking is to repeal the old non-operational sections regarding the diversion program. We did try to put this through. It's called a Section 100 change to the Office of Administrative Law. But there is, in one statute, a reference to the diversion program that I think has to do with reporting. And so they wanted us to go through the formal rulemaking process to repeal those sections. Again, it hasn't been operational since 2008, and it needs to be taken out. Finally, board staff has recently been asked if individuals with a postgraduate training license will be able to participate in this program. The current language, as it's defined here, would not include people with a postgraduate training license, but if the board wanted to open that up, I could make that change and broaden the definition to include those individuals. And so with that, I would ask for a motion, and I'll let I can read it out, or someone else can do it.
May I ask a question?
Of course.
Although this deals with coming into compliance with that which is required in legislation specific to substance abuse, am I correct in assuming that our physician health and wellness program will be more broad and also include psychologic and psychiatric issues, or is this just restricted to substance abuse?
It is restricted to substance abuse by statute.
In any event, I'm happy to support the motion and have you read it.
You want to read it? Okay. Can I have a motion to direct staff to submit the proposed regulation for approval, and once approved, formally notice those regulations and to authorize staff to make any non-substantive changes to the language during the rulemaking process without returning to the matter to the board?
So moved.
I need clarification about whether this board wants to add individuals who don't have a full license and are in postgraduate training with a postgraduate training license.
I think we should, because we know from experience of cases we've reviewed that it's also an issue for those in postgraduate training.
I also agree. I think we should add that because they'll eventually have a license and they should have the opportunity to participate in this program.
Okay. Any other members have any comments on that? Okay. So.
Okay, so.
We need to amend? No, because you asked us if we.
Right. So I'll suggest the motion is that the board authorize the staff to prepare the necessary regulatory documents to submit to DCA and the agency. And upon DCA and agency approval, submit the documents to the Office of Administrative Law to notice the proposed regulatory language to repeal Title 16 of the CCR, sections 1357 through 1357.9, and to add sections 1357.10 through 1357.16 with the addition that we're going to broaden the definition of eligible participants to include those with a postgraduate training license, and authorize staff to make non-substantive changes to the language and respond to non-substantive comments during the rulemaking process without returning to the board.
Are you intending in that motion to also remove 1357.7, which is not specifically listed?
It's not.
Or is there no 1357.7 in existence? I just don't want to remove something we weren't intending to remove.
Yes, not here.
It's not on her list.
Maybe it didn't.
I'm going to double check, but
So
I
as
think
as you
it
read the
skipped
motion,
over.
you stated 1357 through 1357.9. So I'd like to amend that to exclude 1357.7.
That it doesn't exist.
Okay, good. I don't want to remove something that was unintentional.
No, I am grateful for the collective effort to make sure it's correct. I appreciate it.
Thank you. Second.
Okay. Are there any public comments in the audience? Any on the phone?
Yes, we do have a public comment. One moment. Panwar Gill, your line is open. And his line has disconnected. No public
Okay.
comment at this time.
All right. Ms. Cruz-Jones, please call the roll.
Ms. Friedman.
Yes.
Dr. Gonadev. Dr. Hawkins.
Yes.
Dr. Kraus.
Yes.
Ms. Lawson. Dr. Lewis.
Aye.
Dr. Mahmood. Dr. Thorpe.
Aye.
Mr. Warmoth.
Aye.
Mr. Watkins.
Aye.
Dr. Yip.
Aye.
Ms. Pines.
Aye. Moving on to agenda item 22, discussion and possible action to withdraw proposed rulemaking for Title 16, California Code of Regulations, Section 1399.545 regarding the supervision required for physician assistants. Ms. Webb, please continue.
This is a short one with the passage of Senate Bill 697, which changed how physician assistants will be supervised. This proposed rulemaking is no longer relevant in its current format. The Physician Assistant Board took action to approve withdrawal, and I recommend that this board do the same. And they will be taking another look at the regulations to see if a different package should go forward.
I'll move that your motion, or make a motion to after review and consideration, to direct staff to withdraw the pending rulemaking on Title 16 of the California Code of Regulations, Section 1399.545, regarding supervision required for physician assistants.
Do we have a second? Okay. Do you have any comments, questions? Okay. Any comments from the audience? Any comments on the phone?
We have two comments. Karen Miyamoto, your line is open.
I'm with Dr. Karen Miyamoto with the California Society of Addiction Medicine. I just want to bring up the very important point that has been discussed with this board. The inconsistencies and difficulties with uniform standards have led to decreased participation in all the board programs, and that those need to be addressed to have a fully viable program. Thank you.
Thank you.
The next comment is coming from Kenwar Gill. Your line is open.
Hello, my name is Kanwar Gill. Can you hear me all?
Yes.
Okay. Well, I want to first thank Ms. Webb. Her information that she provides is very insightful, sometimes way better than the legislative liaison that the board has. As you all know, beginning January 1st, 2016, Section 1399.45 required supervising physicians to review, countersign, and date a sample of chats at a minimum 5% for the regular records and a little bit higher for the substance that are scheduled in Schedule 2, I believe. The requirement was 30 days for the regular medical charts, and the requirement for the scheduled substance was within 7 days. I have noted that a widespread disregard of the statutory provision occurred in California. I can speak of Central California, about 4 to 5 counties. I'm not sure what else is going on in counties of Humboldt, Mendocino area, but there is something that has to be looked into. But coming back to the point, these regulations were not, these statutes were not followed as the law was written. There was far less compliance with scheduled substances. In some cases, 0% of the charts over several years were not reviewed. And when these organizations and entities found out that they were not in compliance with the law, instead of admitting wrongdoing, they went to their vendors, some of the largest electronic medical record vendors, and digitally inserted a dynamic signatures into the chart, tampering with millions of patient record. And that's a matter of concern. It's a criminal offense to tamper with the chart, especially with the provisions of 1399.45, punishable in a prison, I believe, in 1 year or 1 year in prison. So this is something of a concern. A law is written, there is an expectation it will be followed, it is not followed. Another law is written to push everything under the rug. Senate Bill 697 is one of those, with retroactive provisions to ensure those who violated, even in the disability statutes, the EDD provisions were violated where disability certificates were given by the PAs without consulting the physicians. And the law was written in Senate Bill 697, the retroactive provisions for those being as accurate and as legal certificates was done. EDD is making its own changes now just because physician assistants were writing for disability, primarily for mental health disorder. So why my question is simple: as board's failure to enforce its own statutes, what is going to be done? I think I had previously suggested that prospective review or a concurrent review of these provisions must be made by board on a more proactive manner than to have a complaint process address this retrospectively when the consumer protection issues have been compromised already. Thank you.
Thank you.
No further comment at this time.
Ms. Cruz-Jones, please call the roll.
Ms. Friedman. Yes. Dr. Gonadev. Dr. Hawkins.
Yes.
Dr. Kraus.
Yes.
Ms. Lawson. Dr. Lewis.
Aye.
Dr. Mahmood. Dr. Thorpe. Mr. Warmoth.
Aye.
Mr. Watkins. Dr. Yep.
Aye.
Ms. Pines.
Aye. Thank you, Ms. Webb. Moving on to agenda item 23, update on the stem cell in regenerative therapy task force. Dr. Hawkins and Dr. Kraus.
Thank you. At the July 2018 board meeting, the board was provided a policy that was adopted by the Federation of State Medical Boards. The policy contained several recommendations for state boards regarding regenerative and stem cell therapy practices. At the October 2018 board meeting, Ms. Pines established a board task force on stem cell and regenerative therapy to review the policy and determine whether the board should provide further guidance on this matter to protect California consumers.
On June 27, 2019, the task force members met with board staff to discuss oversight options the board may decide to pursue to protect California consumers from unapproved and potentially dangerous stem cell products or regenerative therapies and next steps. A few options discussed included the development of educational materials, exploring outreach opportunities, and developing best practice guidelines similar to those adopted by the FSMB. The task force also discussed the need for some type of guidance for informed consent. While current law requires notice to patients regarding stem cell therapies, it only requires notification to the patient that the therapy is not FDA approved and encourages the patient to consult with their primary care physician. The task force believes a more in-depth informed consent would be beneficial. In addition, discussion also included the need for adverse event reporting and what would be required for such reporting. It was further agreed that the task force would hold a stem cell and regenerative therapy interested parties meeting to gather information and feedback from consumers, experts, and stakeholders to assist the board in the development of materials and/or determine if there are additional options that should be considered to enhance consumer protection.
On September 18, 2019, the task force held a stem cell and regenerative therapy interested party meetings. Dr. Milan, president of the California Institute of Regenerative Medicine, Dr. Dean, assistant director and acting public health officer with the California Department of Public Health, and Dr. Abedi, professor from UCS Davis, gave presentations on the subject of stem cell and regenerative therapy and discussed best practices. In addition, Dr. Dean provided an overview of CDPH's role in stem cell product regulation and investigation. Further, the task force received feedback from consumers and experts in the field. The meeting was a success, and beneficial information was shared.
Staff is working on compiling the information discussed at the interested parties meeting into a document to be reviewed by the task force. The task force will then work with staff on developing a guidance document for physicians regarding stem cell and regenerative treatment that will include a sample informed consent document and educational materials for the public, which will be presented to the board for review and final approval. That concludes our update.
Thank you. Are there any questions from the members or comments? Dr. Gananadev?
Just a comment. Actually, a good tag team between the two of you.
Any other comments or questions? Ms. Philbin?
You talked about adverse event reporting, that you're thinking of doing a meeting with people coming to report adverse events. Am I correct?
The mechanism of adverse event reporting and those adverse events which would be required to be reported has not yet been fully outlined. But in general, adverse event reporting becomes a requirement on the part of a healthcare provider once we have legislation so requiring it, if that be recommended. And also, of course, we would encourage and collect consumer complaints.
Okay.
From what I've observed, and this is a subject that I am passionate about, there are stem cell clinics all over the country. California and Florida are the two states with the most egregious things happening, because the fact is that taking out somebody's cells and putting them back in does nothing. And some people who have traveled abroad have had horrible, horrible things happen to them, very serious consequences. So I don't know, how do we deal with that? Do we wait until things get really bad and we have a complaint, or just what is the procedure that we follow?
The answer is the task force was designed
Yeah.
to help us deal with it, so it's a work in progress.
Oh, okay.
This is the beginning of that process.
Dr. Lewis?
Yes, and you made a comment about the FSMB, and they have developed their own consent form, which you are going to use as an initial working document, then to fit it into what you think we should present to patients and physicians in California. Is that the plan?
Yes, and we would hope that that comes to the board for consideration and refinement.
Okay.
Thanks.
Any other questions, comments? Any comments in the audience?
Yeah, so I currently am working in a state at an undisclosed location, and stem cell is very popular. It's pretty interesting. I attended one of those dinners where they discuss stem cell, what's behind it, who's behind it, how they're doing it, where they come from, that sort of thing. It was fascinating. And then to meet some of the patients that have benefited from it, it is, from what I've seen and heard and learned, it's a game changer. It's going to change those with chronic diseases, chronic inflammation, African American health. It's a game changer in the state that I am at, and it'd be great to see California get ahead of the curve, but I think you may be a little behind the curve right now. It's very, very popular, and very beneficial.
Thank you. Are there any additional comments in the audience? Any comments on the phone?
No comments from the phone.
Okay. Thank you, Dr. Hawkins.
Just like to make a comment in response to the last statement. There are clinical trials ongoing to evaluate the efficacy of stem cell treatment, but a lot of what's going on is not being monitored, and testimonials happen all the time. They may or may not be accurate.
Thank you for that. Yes.
Yeah, I just wanted to amend what I said before. I was talking about stem cell spas that exist out there. I wasn't talking about the state institute that is doing rigorous research in how to use stem cells to cure various diseases. So
thanks for that clarity. Okay. Thank you, guys. Moving to agenda item 24, future items on the agenda. So I want to put on that we will meet again in January with the patient advocates, and we'll have another 2-hour meeting on Friday after our official board meeting. Dr. Lewis?
I have an agenda item for some time in the future, is if we can talk about social media and the good and the bad for physicians and others, because we do hear occasionally that some physicians seem to have issues with social media, and just like TripAdvisor or whatever, and I'd like to hear more about the use of social media in medicine.
And just for clarification, physicians using the social media or other people posting?
Physicians using the social media.
And using it to advertise or in their practice?
Advertise, and their difficulties when their site has been dinged, and how they deal with those inconsistencies in their practice, and just something about, do you understand, something about what's going on now. We have social media everywhere, and I want to hear a little more about it, especially in the physician side, but could broaden it. Okay?
Okay.
Thanks.
Dr. Gananadev?
Yeah, just as I mentioned yesterday, I do want to look at sometime in future. It might be difficult to get the representatives from ACGME, that is Accreditation Council for Graduate Medical Education, to see how we can get into re-entry, re-education programs for physicians.
Mr. Warmoth?
I would like to get an update on our phone app, specifically on the status of the Android version of the app.
Mr. Hawkins? Watkins?
What?
Dr.
I would, in the future, would like to see three presentations and maybe a discussion. The first one was a presentation from a reputable expert that deals in the area of boundary violations, especially when the undertone is sexual misconduct. And the second presentation is hearing from the licensed midwives, the experts, specifically to present those statistics and the reasons for the grounds on which to prevent this V-ban, and on the opposing side, also from the medical space, of why that is a viable option. So those are my recommendations, suggestions.
Okay, is that it from the side? Okay, yeah. Dr. Thorpe?
I would like to raise at some point in the future, I would like to see a collaboration between the Board of Pharmacy and the board, and our board, the medical board. There is in the community there used to be a very strong collaboration between pharmacists and physicians, and that has become seriously eroded in the last 2 years. There's a very significant adversarial relationship between physicians and pharmacists, and I think that we are in a position to try and help resolve that. I'd like to see, and I'd be happy to talk with you, Ms. Pines, about that in more detail so that we can kind of maybe develop a more specific approach to that rather than just a kind of a broad statement.
Okay.
Okay, I'd just let you know that in prior board meetings before you're on board, we had a good relationship, and I'm not sure about now, with Jenny.
Still do.
We still do. So the executive director of the Board of Pharmacy used to come in and present at least once a year or so, and we have a very good relationship with them through their board.
And vice versa. The executive director would go to the Board of Pharmacy and present.
Yes.
So, great suggestion.
I'm not so concerned about the Board of Pharmacy as the practicing pharmacists. That's where the problem is.
Sure.
Okay, that makes sense. No, I think she retired. Are there any other future agenda items from board members? Okay. Are there any comments from those in the audience?
Thank you for your patience with me. So what I've seen missing from the meetings thus far is just more information. So it's wonderful to see that you're open to more information. So here's a tidbit. There's only, how many HBCUs are there in the state of California?
0.
I guess for those of you, what is an HBCU? Why do I have to know? What's the big deal? What's the importance? What's the relevance? This missing factor, this chronic illness curve with African American patients. So I would maybe ask the board to consider hearing from an HBCU, the one and only designated HBCU in the state of California. Unbelievable. And to hear from them. What is an HBCU? What makes them different? How is their health care different? And that kind of thing. I think that'd be a very, very relevant point, especially hearing earlier from a board member who maybe just need to be reminded of the difference between race and ethnicity. And we generally, with statistics and those kinds of studies, we generally look at race, not ethnicity. And there's a reason for that. So that's it. Thank you.
Thank you. Yes.
Good morning, Bridget Grammy from the Center for Public Interest Law. I just wanted to reiterate my request from yesterday that the board consider these disclosure of payments received from pharmaceutical and device companies, that would be something that the board would talk about. And also, I'm glad to hear you're having another patient advocates meeting. That's great. But it reminded me of Dr. Lewis, of your comments too. One of my students actually presented last year, and we still are working on this issue of the difference between not just social media, but online review. Do you remember this discussion? So my student has done some research and found some significant disparities between online review companies like Yelp or Healthgrades that may have a 5-star review for a physician, and when you compare that to their disciplinary record on Breeze, there's a very big difference, and so that's very concerning to us. And so, to the extent that you're talking social media, I would ask that you add that piece of it too.
Very good, thank you.
Thank you.
Thank you. Is that what you were talking about?
I was talking about the whole thing, but she makes a very good point.
Okay.
It's all of that, social media.
Are there any additional comments in the audience? Any comments on the phone?
We have 3 comments from the phone. Eric Andrus, your line is open.
Another patient advocate meeting, once again in Northern California, even though most of the active advocates live in Southern California. So that means we have to pay for airline tickets and expensive hotels and parking and all that stuff again. I'd like to suggest that you let the advocates run at this time so that the board doesn't hog all the time telling us stuff we already know. Carrie said yesterday that the public could call in and request agenda items at the end of the meeting. Well, that's true. In my tenure of monitoring the board, I don't ever recall anyone getting an actual agenda item placed. I certainly have been unsuccessful doing so. I've asked for years now for all of you to discuss the Public Record Act, and now another person called in and let you know about how the board's outrageously priced documents are in comparison with other agencies. As I mentioned yesterday, Carrie told me this topic is none of the board's concern. Why is she keeping it from you? Why did she try to stifle Mr. Watkins' motion yesterday? I realize she's paid to protect the board, but at what cost? She's going to get you all in trouble for being accomplices to not following the law. You can't hide forever, and as you can see, we're relentlessly watching you. So if you disagree that this is none of your concern, request that we talk about the Public Record Act at a meeting. Try and prove me wrong. And TJ, thanks for speaking out. Hold Carrie accountable.
Thank you. Next.
Comment is coming from Kenmore Gill. Your line is open.
Is it for me, Canver Gill? Okay, hi. I just wanted to speak about something on the website. Medical Board website is a very resourceful, it's a good resource for us, especially the alert section. But what I've noticed is that sometimes we are not able to get the right information. And I'll give you an example. On September 13, 2019, California Department of Public Health sent a notice that in consultation with the California Conference of Local Health Officers, it recently updated Title 17, Section 25 of the California Code of Regulation, in which providers must report all cases of the listed disease. There are about 2,500. Anyway, the letter reminded the providers that there is a change in requirements, specifically changes to the reportable diseases, and many of us don't know that chlamydia trachomatis infections, including LGV, has been taken out from a reportable disease. That's probably the single most reported condition, including the other ones that are amoebiasis and streptococcal infection in healthcare of food handlers. So these have been taken out. There is no change in the CMR form or the one that we used. They've added reporting for HIV for all physicians at all age groups, which was pretty confidential and tight-lipped in the past. They've not changed the confidential morbidity reporting form, adding and deleting these conditions, and there's an expectation of provider to notify. And it is not just an expectation. If you fail to notify, you get a threatening letter in the mail from them saying that they will refer you, a provider, to the medical board action if they make a mistake again. On one end, they changed the law, failed to correct their forms, did not notify providers in a right way, and then they send a letter in the mail saying that they'll notify the medical board for a potential administrative action against the physician. So I think when this kind of communication is received by the board, a good thing would be to put it as alert on the first page. Board has been doing a great job notifying us through that process, not only just the state issues, but on the federal issues as well. And I hope that something as important as these changes would reflect on the alert, and this letter was from September 13th, and I expect that this advice would be somehow taken into account. I'm not requesting an agenda item. I'm just hoping a change. Thank you.
Thank you. Next.
And the last comment is coming from Christina Hildebrand. Your line is open.
Hi there, Christina Hildebrand from Voice for Truth Advocacy again. I have 4 agenda items that I would like to have, which we have some of them we've requested multiple times. The first one is was also requested by Christy Sebulba Burchett of Educate Advocate, and that is and a number of other people, I think, is a training of theirs and a discussion around how physicians are trained regarding to VAERS, the Vaccine Adverse Events Reporting System. It is mandatory for physicians to report adverse reactions to vaccines. However, physicians don't. They don't because they believe vaccines are safe and effective. They don't read the package inserts. They don't even know what adverse events are to vaccines. Shoulder injury is included in that, and they just don't report them. So we would like to see a agenda item to discuss VAERS training, VAERS reporting. We're happy to share experts there. We have many of them. The second one goes in line with the Center for Public Interest Law. I love your bill idea, and we would definitely support it. Our request was, and it can go hand in hand with that, is a presentation on how to practice when insurance dictates patient care. So we find that insurance companies incentivize for certain patient care, for certain programs, including specifically vaccinations, but also things like chemotherapy, radiation. All of those practices are very dominated by what your insurance will allow, what your insurance will is promoting that day. And we would like to have a presentation based on how to practice in that environment, and that physicians should really be practicing from their own discretion rather than being impacted by pharmaceutical and medical device companies and insurance. The third one is a presentation on what is standard of care. So we are finding that while the medical board is investigating that they are holding physicians to standard of care, yet standard of care is what 95% of physicians practice, yet there is a 5% that is expert in their field and are at the leading edge. That's why you go to the Mayo Clinic. That's why you go to St. Jude's, because you want that cutting edge research. Well, our physicians are being held accountable on standard of care, and it is not including the latest research. So a discussion around that. The Knox-Keene Act has an appeals process that includes what scientific literature you can use in order to gain insurance for certain prescription drugs or medical devices, medical treatment. And, that goes beyond standard of care. So a discussion of what is standard of care and how does the most recent research get included in that and not have physicians penalized for using that. And then the last one is what I requested yesterday, which is a number of points to fix the SB 714 and 276 legislation that really hinders physicians from being able to practice.
No further comments in queue at this time.
Okay, thank you. So before we adjourn, I'd like to recognize Ms. Friedman, who will soon complete her term, unfortunately, with the board. Ms. Friedman began serving on the board last December in 2018. In that time, she has attended several outreach events, served on Panel B and the Physician Outreach Education and Wellness Committee, as well as the editorial committee. We'd like to thank her for her diligence and dedication. And Ms. Friedman, do you want to say a few words or come forward?
I've loved doing this work. I've loved reading all these interesting cases. As a former news reporter, obviously it gets my blood boiling half the time. And I've loved being a member of this group. And I'm just hoping that somewhere down the line, all the contacts I made will reverse this. However, it probably won't happen. So I want to say goodbye to all of you, but I look forward to hearing about all the wonderful things you'll be doing in the future.
Thank you.
Thank you.
So we want to present you with this plaque.
Thank you. So sweet. Thank you so much.
Now we adjourn. Now we adjourn.
So the next agenda item is adjournment.